Hi, this is Neil Hansen. I'm taking you through a CT enterography. So the protocol for a CT enterography is a little bit different than your regular abdomen and pelvis CT. The indications for CT enterography usually are related to inflammatory bowel disease. The main difference between a CT enterography and a regular CT is the type of contrast given. So I'm going to bring up a coronal image and show you the bowel. So the bowel obviously doesn't have high attenuation barium. We give something called negative oral contrast. In this case, our institution gives volumen. It allows you to see the bowel wall to much better advantage because the high attenuation oral barium or gastrographin or iodine-based contrast can cause obscuration of the mucosal surface, kind of limiting your evaluation to diagnose acute inflammatory bowel disease. Here you can see the bowel is mildly distended because frequently these negative contrast agents act as a osmotic agent to bring fluid into the bowel for the purpose of the scan. Patients don't like it. It frequently makes them a little distended and nauseous. It's not uncommon for them to vomit. So the technologist may call you and say, hey, we gave one can of volumen. Do we really need to give the second? The answer should always be give the patient as much as they will tolerate because optimal bowel distension is key to diagnosing some of these. In this case, this was a normal CT enterography. There was no evidence of inflammatory bowel disease. Of note, you'd only want to get a CT enterography in the non-acute setting. So it's used to stage Crohn's disease to see if there's active inflammation and to assess disease response to therapy. If someone was presenting even with a history of Crohn's disease and an acute abdomen, I would go with just a single non-oral contrast CT scan via an emergency protocol. So they would get intravenous contrast but no oral contrast because you wouldn't want to wait to give them the volumen, which takes a period of time over an hour kind of to get in and maximally distend the bowel. So this is only in the non-acute setting. I'm going to show the case of a known Crohn's disease patient just to give you an example of a positive scan. So this was a coronal image obtained after drinking volumen, a negative oral contrast, and after IV contrast. So you can see here, this is the terminal ileum. It's thickened. So normally the bowel wall is almost imperceptible, 1 to 2 millimeters. Here it measures up almost a centimeter, and there's something called mural stratification. What that means is that you can see the different layers of the bowel wall. Here's the hyperenhancing mucosa, and there's the relatively lower attenuation muscularis layer. So this mural stratification is a sign of active inflammatory bowel disease. Additionally, if you look here, oftentimes you can kind of barely see the mesenteric vasculature adjacent to a bowel loop. This is called comb sign, where you can see it, and it's much higher in number in terms of the mesenteric vessels supplying that segment of bowel than normal. That's just a sign of hyperemia and active inflammation again. On these studies, you always want to look for active inflammation, abscess, perforation, and fistula are kind of the key findings you're looking for on a CT enterography to guide therapy. In this case, this whole segment of inflamed terminal ileum was mildly narrowed, but the upstream bowel was normal caliber, so there was no obstruction. However, I'll tell you in clinical practice, it's frequently a cause of obstruction in Crohn's disease to have a narrowed segment of bowel with either fibrostenotic disease or acute inflammatory bowel disease that results in acute stricture, or in fibrostenotic disease, a chronic stricture, accounting for a bowel obstruction.